So while she's doing all of that, it is my privilege to introduce Jennifer. She is our ASL interpreter for this session. And as a lot of you know, poor communication in pharmacy can really lead to life and death. And I want to share a quick story that really exemplifies the importance of communication, and especially ASL when it comes to pharmacy. So I want you all to just think back. The year is 2020, all right? COVID is running rampant. I was still working behind the counter in the pharmacy, and we had the mask mandate, so everybody's wearing a mask. And then the plexiglasses went up, and of course, the pharmacy was one of the last places anybody wanted to be because they knew, I'm going to get something. I might get COVID, I might not, but I'm going to get something at the pharmacy, so nobody wanted to come see us. However, that doesn't mean that the show stopped. The show had to go on, and so counseling still had to be done. And so here we had a situation where we're wearing masks and we're got plexis up because we're trying to protect ourselves, yet we've created a hazard. We've created a hazard in communication. And I tell you this because it took us not very long to realize we were not able to communicate with a lot of our elderly patients. Why do you think that is? Right, we had no idea. Lip reading is what she said. We had no idea the number of lip readers that we had as patients. Exactly. There are a lot of people who were lip reading. So throws us into a panic. We're like, we have got to get the right communication out. We are in an industry that is cut and dry. It is black and white. It is life and death. So if our patients don't know who, what, where, when, why, and how with their medication, then they're leaving our pharmacy with a disservice and potential error. So what we did is we took a crash course in ASL so that we could start working and making sure that our patients understood everything they were supposed to before they walked away from that pharmacy. I think we were even making up, pharmacy slang gestures just to get people to understand what we needed. So the reason I bring this up to you and that Jennifer's actually telling you all of this is because I hope that you will realize that there's accommodations that you're not even aware that you may need that accommodation when you're working with your clients. So when you end up having to go into that hospital setting, they're asking you to wear a mask in that hospital setting. Ask your patient, ask your clients, are you a lip reader? Are you hard of hearing? Because that way you'll know and you can accommodate in whether it is ASL, if you know that, or if you need to write on a whiteboard, whatever it is, you're going to need to make that accommodation because people don't tell you. People are not going to tell you, I have a hearing problem and I'm a lip reader. And so I want you to have that thought going forward so that you can be the best advocate for your client. Thank you for letting me share that little story. So let's talk about polypharmacy in the older adult population. Polypharmacy, big word, right? Huge word, but what does it really mean? It just means that we are taking multiple medications and we're going to use those to treat a single condition or an ailment. How many of you have seen medicine cabinets like this? Right? Almost everybody, or they are worse. Well, we are going to talk about what really causes these medicine cabinets to look this way. Our main causes of polypharmacy multiple providers, chronic illness, self-medicating. That has been on the rise for the last couple of decades. Poor medication reconciliation, and a lack of deprescribing. So let's get into these and a little more and talk about these. Multiple providers. All right. I do want to point out, do you see that little red asterisk up there? Okay, I want you paying attention for those. I want you counting how many of those that you see through this presentation, because they're key, they're important. But looking at the number of providers, on average, a person 65 and older is going to have at least 3. And they're going to be primary care, number of specialists, usually a disease coordinator, multiple pharmacies. And do they all communicate with one another? No, and we know this. We know communication is a problem because nobody's talking to one another. Does your client or patient think they do? Yeah, I see a lot of head shaking. Absolutely, they do. And so having more people in working with one patient, you can see how we can end up in that polypharmacy situation. Chronic illness is another cause of polypharmacy. And this is the one that just happens. All right. So the CDC says that chronic illness is a condition lasting longer than a year that requires ongoing medical attention or reduction in ADLs or both. And we know as we age, we develop more chronic conditions. It just happens. So the more chronic conditions and we have specialists, we end up with more providers and we have more difficulties with our ADLs. But self-medicating has just erupted over the last 2 decades. And why? Well, here are your 3 main reasons why people are self-medicating. And cost is the number 1 reason. If they can save themselves a copay at the doctor's office, if they can save themselves money in transportation, and they don't have to go visit the pharmacy, and they got the coupon that they can use too, heck yeah, they're going to self-medicate. They're saving a whole lot of money. There other aspect that I try to really look at this is we all talk about how important it is to stay autonomous and how we keep our clients autonomous. Control. How many of you want your control of your medication regimen taken away? Right answer, right, unless you're sleeping. How many of you want to be in control of your own medication regimen? Right. And who knows us better than ourselves? So we self-medicate because we know what's going in our body, we know what we want to put in our body, and it saves us money. We have lots of outside influences that are a key to self-medicating. Commercials all the time, depending on when you're watching TV, they know who those people are. They are shooting their commercials of their drugs, whether they're prescription or over the counter, they're coming to you. We're bombarded with it. Even as we're scrolling on our phones, you're seeing it there too. So there's a huge outside influence through commercials. And friends. How many of you have had a friend that says, oh, I just tried this product and I absolutely love it. I think it would work so well for you. I have friends like that. Absolutely. And if it's a trusted friend, I'd be like, yeah, okay, I may want to go try that. I may get that, over-the-counter pain rub and put it on my hip after golf or something like that. So friends are huge influencers. But so are pharmacists and their personnel. How many of you have gone to the pharmacy and said, what do you recommend for? Right? All the time, all the time. So we then are influencers on that. We talk about, oh, all right, you have this, you have that. Right down that aisle, left-hand side, 3rd shelf down, purple box. And so all of these outside influences have made self-medicating just erupt. And so that's one of the reasons that polypharmacy really is becoming a problem, because a lot of people don't consider self-medicating as a cause of polypharmacy. They think that's only prescription, and it's not. Poor medication reconciliation. I say poor because it doesn't happen all the time. We know that. So when should it happen? Well, it should happen at your regular doctor visits. Every 6 months, 12 months, make sure that you're having an entire reconciliation done. Anytime we have a transition of care, there should be a reconciliation of medications. You've got your home list, okay, going in for a procedure into the hospital, you take your home list, and then you check it with what they're given in the hospital, all right? Not always this happens, not always same thing, something might get dropped. Then there's the addition of a new medication. So every time you get a new medication, you need to make sure that it plays well with others. So there should be a reconciliation on that too. But it's not happening. And why is it not happening? Because we're talking about poor medication reconciliation. And time constraints are the number one reason. How many minutes, when you go into your doctor's office or you go with a client, how many minutes are you afforded in your visit? 10, 11, 7? Okay, is that enough time to go through an entire med rec and be there for the ailment that you're there for? No. And we've talked about communication. We talk about communication all the time. There is the lack of communication between the patient and the provider. There just is. And we have, could be health literacy, could be fear, could be don't know what to ask. And then providers are up against their time crunch, so they aren't asking right questions. We also have multiple pharmacies. Hard to control where the meds are if they're in multiple places. And then our multiple providers. So all of these barriers are what we need to overcome in order to help our clients get proper med rec. And our last but not least cause of polypharmacy is a lack of deprescribing. How many of you have heard that buzzword before, deprescribing? Okay, a few. So deprescribing basically is we're going to reduce the number of medications that a patient is taken. But there's a lot of barriers to that too. We just talked about that time constraint. We had 7, 11. If you're lucky to get a 20-minute and you actually get all of that time, it's still not enough time to do a full med rec and then decide, oh, well, maybe we should look at pulling back on this med or that med. We also have the lack of communication, provider to provider. Who's going to do the deprescribing? Who's it supposed to be? We'll do questions and comments at the end. That's okay. Write it down because it's going to be good. And then we have lack of provider education. Not all of our providers out there are trained in deprescribing, especially for adults and adults over 65 with a laundry list. So who do we take it to? We'll talk about that. Before we get into what the effects are of all of these causes, I want to just take a brief minute and talk about physiological changes, because these play a key role. So as we age, we know that we end up with decreased motility, all right? Things don't move as fast as they used to inside and out because we also have decreased mobility. Physical movements are difficult. ADLs are having a hard time getting those done. But in the body, as we have a slower motility, we have increases and decreases in absorption, metabolism, and excretion. So even though things may get slower going through, we also may have some increases. And our cognitive impairment that happens as we age. For the majority, we hope it's just the forgetfulness. But we also have to consider dementia, Alzheimer's disease, and how those are going to play a role in medication safety. And then the change in senses. We just talked about the issue with hearing and the lip reading, but we also know that sight is something to go. Touch. People end up with neuropathy. People end up with conditions where touch is a big issue. And so also when you look at taste, we know taste and smell are connected. And so that could be an issue also. Can't taste it very well. We can't smell what's going on. And that can lead, that could lead to issues down the road. Big thing I want to talk to you about. Let's get into some of those effects. How many of you have heard of a prescribing cascade? Okay, let me explain to you what a prescribing cascade is. When you have multiple conditions, they come with complex drug regimens, all right? Complex drug regimens, they're leading to increased side effects. The increased side effects, because people don't like them, it is very common that providers will then treat those side effects with an additional medication. So you have condition A, and you were prescribed, let's say you were prescribed pill B for condition A. Pill B causes a side effect that you don't like. You tell your doctor. He says, oh, we can take care of that with pill C. Okay. Pill C causes a side effect that you really don't like. Oh, don't worry about that. We can treat that with pill D. And so now we have B, C, D. We have 3 medications that we're treating for the A condition. But we're not really treating the A condition with 3 medications, are we? No, we're treating side effects. But now we have 3 pills, and we are definitely in that polypharmacy headed. We are going there. And so I just want you to understand how this prescribing cascade works, so that you can keep this in mind as you're working with your clients and you're talking with their providers. The most common dangerous side effects. Folks, this is your bread and butter. As advocates, you need to know this stuff right here, because this is where you can make a big change. The prescribing cascade is one. Time tracking, multiple times a day dosing. How many of you have ever been able to make it through a 4 times a day dosing, 7 days a week regimen? I'm so proud of you. I am so proud of you. I wish I had a gift just for you, because she's the only one that raised her hand on that. Exactly. It is so hard to get through a multiple time a day dosing. And the more times a day that you have to take medication, the harder it gets. We have Parkinson's drugs that people are taking 5, 6, 7, 8 times a day. And so their schedule is nothing but take medication, take medication, take medication. Oh, maybe I have enough time to, go to church, come home, take a medication. And so if you, as the advocate, can work with the providers to maybe change some of those down to twice a day, maybe down to once a day, then you are going to have a lot better compliance with your clients and patients. So the multiple times a day thing is something that you can definitely look into a little more and see if that is where you might be able to step in. Drug regimen adherence. We are talking about this all the time. If we can keep our patients adherent on their medications, then we're not going to have extra problems. And we will see that their life will just be so improved by making sure that they stay adherent. How many of your clients are adherent on their medication? Right? They're not. We have missed doses. We have double doses because, they remember they missed a dose. I'll take 2 without even looking at it, considering it, remembering what anybody said, months ago when they were actually in a consultation about it. And so helping them stay adherent and explaining how it is. This is a 90-day supply. This is a 30-day. You're getting down to the last bit. Okay, let's stay adherents. Let's get those refills ordered, get them on auto refill, whatever it needs to be. But then we also have the accidental overdose. And this happens because in the pharmacy industry, things look alike and they sound alike. It is not uncommon for your client to have 4 white round pills in their pill box. And they have different markings on them, but they're very similar in size. And so we take a look at that and not knowing what's what. Maybe they put 2 of the same in because they got interrupted in having to answer the Jeopardy question. Okay. Multi-pharmacy is dangerous, and here's why. Because the patient assumes 2 things. One, they assume that all pharmacies are connected across the nation. They're not. There is no federal system like Medicare across the nation for pharmacies. So unless you are under an umbrella type company of Kroger, CVS, Walgreens, something like that, where you can see it nationwide, then there's, issues of having these multiple pharmacies and they don't know what the other pharmacy has. And so that leads to poor medication reconciliation. That can lead to aspects where they could miss medications, be back in the hospital. And then I want to explain that ownership of prescriptions. So the pharmacy who gets the prescription owns it. All right. The only way another pharmacy can really have that prescription is if it gets transferred. And then they take ownership of it. So we transfer a prescription. The first pharmacy only has the information up to when it was transferred. And the next pharmacy only has the information going forward. And patients assume that, no, really all you did was just transfer my fill, and the prescription is still good. But there are so many federal and state laws out there in transferring prescriptions that patients end up losing refills just by law. People forget to transfer back. So we've got issues with that too. What about those OTC supplements and herbals? Yeah. So just because they're over the counter does not mean that they are safe. Here is where we talk about how herbals and supplements can really affect that metabolism and whether it increases it or decreases it in the absorption of it, and then how it's going to leave the body. Those items can actually make your medication regimen maybe a little more toxic or subtherapeutic. And now we've got problems on both sides. So it's really important that we're looking at all of that. And I want you to keep in mind that all the vitamins and supplements are not FDA approved. So that doesn't mean that you're going to have the same quantity of whatever drug it is in that capsule. You could have a lot of in this capsule versus a little bit in this capsule. And so you're constantly kind of playing roulette with your body on the absorption thing by doing this. So it's important that everybody understands that. So we've looked at all of our causes. We looked at the effects of having polypharmacy. How do we take care of that? Where do we step in? What are those best practices? And let's take a look at each one of these. Reduce the number of pharmacies. So on average, an older adult has 3 or more pharmacies. They've got their favorite, they've got mail order, and some of them may have a compounding or infusion pharmacy that they have. They're not all talking to one another. So if you can help them either transfer back prescriptions, get everything back to one pharmacy of brick and mortar, and then go ahead and bring in, maybe go to an umbrella where you can have mail order as part of that. So anytime you can reduce a pharmacy for people, that's an excellent way to reduce polypharmacy. Changing providers. Well, this one could be a tough sell But here's what's happening with this, because we are seeing more and more change. It's hard for the patient because they are loyal to their current PCP. They have that understanding, and there's fear of moving on to somebody else. However, as the population ages, there's not enough PCPs out there to be handling all of this change. And we've got new ones coming out, and some of them are really specializing in geriatrics. So a lot of PCPs are moving their older patients to geriatricians if possible, because geriatricians can give more time. They do more age checks. They also know how to deprescribe. And so that's something that we're going to start to see a trend moving. We're also seeing more of our young medical professionals coming in to where they're specializing in gerontology. Comprehensive medication reviews. How many of you are doing MedRecs for your patients? Thank you so much. That is so needed. Here's where the change comes in. You get a list from your client. It's 20-some medications long. You've never heard of some of them. And you look at that and go, holy cow, I didn't even know what this disease state is. Then you might want to partner with a certified geriatric pharmacist or someone who has the training in this to take that deeper look. A lot of these pharmacists partner with geriatricians. They work as teams because they want everything reviewed. They want, by a pharmacist, they want the recommendations of what can be deprescribed and how to do it. And then they look at that with the pharmacist and we make a plan of action going forward. Reviews, as you can see, they include a lot of things, but not everything. And another difference of why you may want a pharmacist to be the one who is doing the review comes into drug appropriateness and provider appropriateness. And that's something that you just may not understand. We know communication is huge, but do patients take responsibility for communicating with their providers? No, they don't. They don't. So it's part of our jobs to educate them on how to do that, because we really want them to take that responsibility. But if not, okay. If you have those savvy seniors, help them with apps, phone apps, or computer apps, whatever they want. Teach them how to use their patient portals and teach them to use them correctly. We see now that some people are getting hit with copays for using patient portals. What's appropriate, what's not. And if they are the silent generation, well, maybe they prefer a wallet card. Maybe they want to change that out all the time. But maybe they don't want to do it at all. And so they want you to be the provider coordinator. All right, you guys can step in and do that. In-home medication management reviews. This is different than MedRecs. So this is where you're going to manage the medication. So someone comes in, they help set up the system that the client really needs for them and the caregiver. So this could be automated reminders. Jeff was telling us yesterday about the wagon wheel of medication, but there's all kinds of things out there to assist your caregivers and your clients to make sure that they're doing it right, that they're getting it as they need it, and they become more adherent. But maybe they don't want to deal with it. All right, so you manage it. You make sure that it's set every week or month, or that the batteries are still working well in the audio assistance that they have. Okay, that's a good thing for you to do. What I want you to take home from this is that I just want everybody to get involved. Polypharmacy is not going away. And in some instances, polypharmacy is becoming the gold standard in certain disease states. Okay, we see that, and we see that it works. But it doesn't mean that these other 15 things on their list are all necessary. So collaborate with the caregivers and understand what their issues are, how you can step in and help. Partner with the advocates. because when it comes to medication safety, like I said in the beginning, it's black and white, and it can be life and death. So reach out, ask the questions, because there are a lot of us pharmacists who are willing to help you. And I want you to always question, could it be the medication? Because more times than not, it is. New side effect happens, something changes, change in the absorption and everything else. It could just be your body changing even to a medication you've had for years. So keep in mind, it's the medication. And then I also want you to, if you question it in your mind, please speak it out your mouth, because you are not the only one questioning it. And you may have the question that also has the answer. So please just get involved one way or another so that we can actually have safer regimens for all of our older adults. Okay, I told you to do those asterisks, right? Count up how many asterisks. Did anybody count them? How many did you get? 12, yep, 12. So if you take, there are 12 opportunities for you to help break this polypharmacy change, that you can step in and do it. And then in this interactive case study right here, it walks you through that. We talk about everything in detail with patients in this case study. So I want you to go ahead and take a picture of it or open it and follow along. And with that, I am going to go ahead and open everything up for question and answer. And I'm just going to leave this here while you guys are all checking it out with your phones. Thank you so much for listening to me on this morning.